start our meeting.
Should I change the clock real quickly?
Sure.
We've done that before.
Yeah. Mickey Mouse business.
Batteries probably getting weak.
Good.
Well, we want to start in the, if I could move the dial correctly.
Let Jan do it, Charlie.
She probably do it much better. There.
All right, let's give a pledge to allegiance to the flag, please. I
pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. I don't think we have any public comments, so we'll move on to approve of the consent agenda items. Anybody have any comments before we approve that? If not, I'll ask for a motion.
I'll make a motion that we approve the consent agenda.
Second?
Moved and seconded. Those in favor?
Aye.
Aye. How about you two down there?
Aye.
Aye.
Okay, thanks.
Thanks for observing.
Unanimous, thank you. Budget committee members, Charlie.
At our last budget meeting, all of you were in attendance. One of the things that we had not brought to your attention was that a couple had expired terms and that we needed to re-approve their 3-year term. Those individuals were Don Lassley and Joni Bogarts. Both of them agreed to extend their term. The budget committee agreed to that extension. It needs to be ratified by the board. So I would recommend to the board that you reappoint those boards.
So moved.
Budget.
Second.
Moved and seconded. Those in favor?
Aye.
Aye. Thank you. Unanimous. April financial report.
Excuse me, are those 4-year terms?
3.
Or 3?
3-year
They're
terms.
3.
If I misspoke, it's 3-year terms.
3-year term, yeah.
Cheryl?
Yes. So, actually, oh, the budget at the end, what are we talking about? Oh, okay, sorry. I was prepared to talk about the budget first, second.
Thank you.
Fine. Got it, okay, all right.
I'll keep going.
Okay. We had a month that was slower in April than it was in March and February for the hospital. So we were down to 345 patients. A big year-over-year looking at this, the emergency department's down by 293 patients. Our surgical outpatients are down by 63 year-over-year. One thing I guess I'd like to mention about that is Dr. Bradbury's here this week and next. I think he had one day with 7 surgeries in it. So he is going to be crazy busy these 2 weeks, and we might make up that number a little bit before the end of the year. So that's cool. Yeah. Looking down at our ancillary services, we are pretty strong all across the board. We are up year-over-year in every category. This is, pardon?
Yeah.
Oh, we missed, the huge increase here is rehab patients. That is a 20% increase, which is huge. So that's pretty exciting. And I can believe that this is pretty much the health clinic. We had a slow month in the health clinic. We had one doctor out sick for a few weeks. We had one doctor out on education for a few weeks, and so you can really see that impact. However, year-to-date, 9,000 patients. We had just gotten started last year at this time, so not very many, but I think really this is where a lot of those missing emergency room patients have gone, which is great. Really nothing notable in the census. We like to stay. 13, 14, 15, 16. Our current average monthly revenue is $2.386 million. Our revenue for this this month was 2.35 million. So that's down from the last few months, and it's a little bit below average, but still a very good year. Our days in AR is now at 80. It's high, it's stayed high, it's down a little bit from the prior 2 months. It's not down as much as I thought it would be. The AR is down a bit. The collections were pretty low this month, I think a lot more than I anticipated, so I would think we're gonna make it up in June, because they really weren't as high as they should have been, and I'm not really sure why. Do you have any feelings on that?
There's a delay in swing bed payments. That's
Oh.
a large,
The Medicare just across the board with all swing bed recipients
yeah,
put everybody on hold, but that's resolved.
yeah.
That was resolved.
It seems to happen like once a year.
It does. No one in the world got paid for swing beds for a little while. Okay, so, collections on our AR was down, like I said. Our collections for the month were just about 1.7 million, which is down a couple $100,000 from the prior month, and a little bit below our average, but not very much. And I would have to think that we should see a pretty good bounce back next month, given, you know, the revenues we had in March and February. So with cash down a bit, so is our days cash on hand. It's down at 146 days now. Okay, the profit and loss, current month is here. We're very close to budget on our total operating revenue. We're very close to budget on our operating expenses. Our net profit or net gain for the month was 71,000. Our operating loss was 120,000. It's kind of just an average good month. Year to date, we're 774,000 short of what we budgeted to be, but we are $2 million ahead of where we were last year at this time. Expenses are $1 million below budget, which is expected with less revenue. And our net gain for the year right now is 492,000, 402,000 ahead of budget. Okay, and I think what I kind of wanted to mention, because our net revenue for the month was very close to budget, but I told you our gross charges were down a few $100,000, right? So, did y'all notice that? So I kind of wanted to explain that in case you started to think about it. One of the sheets that I send you on the detail is the sheet where we compare our cash collections with the revenue we booked. And this month, we were actually a little bit, it was a little bit negative, which means we've not maybe recorded enough revenue. So another thing that I do is I look at our total revenue to date and our total contractuals to date and what that percentage is. And right now, that percentage is 22%. We've recorded 22% of our revenue as a contractual expense, deducted from our gross charges. On the balance sheet, we are showing a contractual allowance of 21% on our AR. So if that had been super high or low, I might have made a change to the current month. But because we're really where we should be, I didn't change the current month. And contractuals for this month were just low. They were really only at 16%. So that's why our net revenue was pretty good in spite of the fact that our gross charges weren't really where we expected them to be. Clear? Okay.
Because it'll make up over time, not just the specific month.
Yeah.
We're estimating our contractual adjustments every month, and we true it up as we go on a year-to-date basis.
Because you don't want to have a big adjustment in 1 month. But this was kind of an odd month, the contractuals were so low. So for whatever reason, more collections on maybe sort of Medicare than commercial payers. So just sort of an anomaly. Our balance sheet, there really was no changes. Our cash is down a little bit, the AR is up just a little bit. Otherwise, there's really no change month to month. We are buying big assets and doing things. Okay, so any questions on my health district? Okay, so then we need to talk about the budget. And I know that all of you were at the budget meeting, and I mean, I can certainly recap some discussion of the budget if you want to. I brought copies of the budget, but I think you guys kept yours at
Anybody
home.
need to know that?
Not I.
Been there, done that.
Yeah.
We spent enough time on it. All right.
But I would say that I thought the process went very smoothly, Cheryl, and the information was very accurate and well received. Thank you.
Good, so we'll try to repeat that next year.
Good.
Okay. All right. Oh, that's right. We reset the capital. I'm sorry, I totally forgot about that. And I highlighted the changes. Okay, so we're all okay with that.
Those are two pieces of equipment that, one case, we're anticipating the potential that we have to replace a piece of equipment, and we don't have to, but there is some concern. That is a piece of equipment that is used, it's owned by CARES, is used here at the hospital, and it may be moved to public health. If that happens, we would need to have one here at the hospital. So we would need to buy a replacement piece of equipment.
But it's really used in the clinics, right?
It is used predominantly in clinics. So it's used by both Warner Mountain Clinic as well as Lake Health Clinic. So that just came up after we went through the budget committee. I was advised that might be a potential. The other is a piece of equipment that we've talked about over the years as a possibility. We want to put that in should we choose to use that. We don't even have a space to put it in here. So that's the DEXA scan system.
So do you need a motion to approve the budget?
With those changes.
Okay.
Please.
Also move.
Second. Moved and seconded to approve the budget with the changes in capital expenditures. Those in favor? Aye. Thank you.
Okay, so then moving on to Moose Lake and Lakeview Gardens. Starting with Lakeview Gardens, hey. Sort of, come back here. Sorry. Okay, so, we had a drop in our long-term care days. We had pretty strong March, February, January, and I guess it's better than January, but it still is a little bit less than March. So the good news there would be that we've had a pretty good census the last few months, and I think we have a waiting list right now. So
Really?
yeah, we have a waiting list. So
3 people actually.
wow. So that should continue.
The last 3 weeks.
Yeah.
Part of the reason we have not accepted those is because it's becoming more and more common for people to request private room. We have not been able to accommodate that. Historically, our rooms have, they are designed for 2 in a room. And people have been quite adamant about their interest in having
So,
private room.
Charlie, along that same line, will we have enough space in our 2 new long-term care cottages for the census that we might have?
Well, it is our hope that we would have a waiting list that would prove the need for a 3rd long-term care cottage. Some of the patients that we have might potentially, that are in our house currently, might potentially fit into the assisted living cottage. So that we might see an overall drop because they might go into the assisted living rather than all be in long-term care. That isn't an option right now. So that, but the goal would be that we would, if you recall, our studies that were done indicated that the demand for long-term care and assisted living would easily justify, if they estimated we could use 45 beds in long-term care, and I think it was 30 beds in assisted living. I can't remember exactly the numbers, but it's quite a bit more than we believe is what our market says. That's due to the aging of the population and other factors. So we build a nice one, and we do build a waiting list. We have space to add an additional assisted living closer to 9th Street. And we would have the ability to add 2 more cottages should the demand be there for the long-term care. For long-term care, we would have to go through the certificate of need process, same process we've gone through.
Okay. So with the census drop, the revenue dropped a little bit. We started building out a PCC for real. And I feel like the revenue is quite a bit lower than maybe it should be. So I am still, we're still auditing to make sure we didn't miss anything. And we'll have to work with PCC to make sure that that's really working the way it's supposed to as well. Huh? Oh, Point Click Care, the new software that we're using for long-term care. Yeah. It's going pretty well. It's been pretty well received, and the staff down in long-term care are certainly liking it. So, but we in the business office and the accounting are always kind of at the tail end of all those changes. So we're just getting to experience our learning curve. So we'll see. All right. So for the month of April, the revenue is $147,000. Expenses are high because there was a $40,000 tax bill this month. And so we had a loss of $84,000 on the year. We're at a loss of $201,000. I kind of think, I mean, my feeling is we're going to make up some of that before the end of the year. I think the next 3 months are going to be good, and we're going to end up pretty close to where we were last year at this time.
What's our percentage of Medicare or Medicaid now in long-term care?
Between Medicare and Medicaid?
Yeah, to hit that magic 80% so we don't have to pay the bed tax.
I don't think we're close to it. Every time we look at it, we are.
Any chance that you could split that up into each building?
Yeah, we could have a Medicare building. Oh.
Oftentimes, what we find is that which causes us not to meet the minimum or that threshold are the private pay patients.
Right.
And so if those patients might appropriately fit in the assisted living, that could have a significant benefit to us.
Okay.
So that's usually the factor that causes it.
And the balance sheet, I don't know why I didn't copy in last month's for you here, sorry about that. It's on the worksheet, but really no change month to month. The AR is pretty close to where it should be. The cash is kept low because we're paying down on the debt. And so that's about all the activity this balance sheet sees. Okay, questions anymore on the government? Goose Lake Medical, their revenue continues to decline without enough providers down there. The good news is Tony actually heard from the state of California that they have everything that they need to process his license. I don't know how long that would take now, but they said it would be about a month. So hopefully that will be very soon.
We also have Dr.
Barsakova.
Dr. Barsakova starts next
Right?
week.
Oh, next week, mid-June. Okay, so, yeah. Tatiana Barsakova. She's a permanent candidate. She really wants to check out. She thinks she's very interested. We think that she's a great candidate, but
She has a California license.
Yeah, has a California license, so she's gonna be working in, I imagine she'll need a little bit of ramp-up time. We're gonna have to move people around a little bit, so it'll be a little disruptive, but
She went from Florida?
I think that was probably right. She's from far away.
Yeah, I think it's more.
Yeah.
Yeah, she'll be great.
Yeah, she seems really good. She does not have a very good accent. She's really nice to talk to. You can understand well. She's very down to earth. All right, and so our revenue, our average revenue is down. For the month, we lost, I don't remember what now, but year-to-date, we have a loss of 104,000. Compared to last year was 13,000. And our balance sheet, no real change. We haven't really started seeing a lot of cash flowing on the AR yet. And no other change in really their situation.
That's a big difference between year-to-date or prior to actual.
Prior and current, yeah, this year and last year, yes.
Do we expect that AR to come down?
Yes, we do. As we're getting it built out and start collecting on it, yes. There still is a lot of charges that the doctors have to finish their work on, so we can drop those. We're struggling to get them to do that.
What year did we open that clinic?
2010.
But, I mean, the other thing would be, I think you could bring in a provider and you wouldn't need to hardly add any staff. You know, they should be able to perform a provider and a decent provider should be able to produce $40,000 to $50,000 a month of revenue. And that would almost all go to the bottom line. You just find somebody who would work.
We do have somebody. Tony's ready to talk to
Yeah,
us.
Tony's awesome. Yeah.
Trying to figure out how long it'll be before 28 million is gone.
28 million.
Do we have in the hospital district now? This is nibbling away.
Okay.
Any other questions on the finances? All right, Charlie, you've got something on a mutual aid agreement.
We have, this is an agreement between Lake Health District and Lake County School District. I believe we sent out a copy to you on this. This is an agreement that, working with the school district, we need to redo. It has been approved by the school district. I think it's pretty straightforward. I recommend that we approve this policy.
Is that an annual?
The way we've had it is just ongoing. But when we had a survey, they said, you know, you need to revise it, even though none of the terms have really changed.
They want us to review it annually, have them and us just do a quick review annually. The reason we had to redo it is it used to say Lake Health District, or Lake District Hospital and long-term care. So we had to separate the two agreements.
All right, I'll ask for a motion.
So moved.
Moved and seconded, those in favor?
Aye.
Aye, unanimous. Thank you. Medical staff privileging, Charlie. I didn't see it.
They were there.
Were they there?
Several.
I missed it.
These are,
Radiology seemed to be the top of the list.
Yes, it did.
unfortunately, one of the things that happens is a lot of the radiologists are not the ones that are consistently there, but rather the after-hours radiologists. So we get a churn just because they come and go a fair amount. Other practitioners are, that are local, Dr. Lee, Lisa Cahill, Dr. Schroeder, generally local, but has been here for some time. All of that was continuation. So, yeah, Dr. Hussey was not able to be here tonight. The medical staff approved these privileges and recommend to you that you approve these.
I'll move that we approve the medical staff privileging as presented.
Second.
Moved and seconded. Those in favor?
Aye.
Aye, thank you. Approved unanimously. Clinic remodel architecture firm selection.
Okay. At our last board meeting, we talked about the 4 different companies that we had as options, and you gave me authorization to negotiate the best deal possible. One of the firms was, no, this is not the one I want to say. One of the firms that we had as an option to select. As we worked on the negotiations, we came up with a different firm that is ZCS out of Klamath Falls, is the company that we selected to negotiate, or excuse me, that we selected to do the clinic remodel project. Right now, that consists of one thing, and that is to come up with a design of the, as you just saw in that area, so they're going to be meeting with our doctors, meeting with staff, trying to come up with the best option before we move forward on any other, trying to get an estimate of cost. So the initial phase is a $30,000 consulting component. It is not the full component that each of the firms did. As you recall, one of the challenges was how do we break out to the full package, but we don't know exactly what the cost is going to be. We tried to narrow it, and as we did that, we got down to some of the cost projections done by the architectural firms. ZCS became the firm I selected. So it's a little different from what you had, the minutes had said. So I just want to make sure you're aware of that. I don't know if you need to approve that change, but we have that available if you want to.
I think we probably should, because when I read the minutes, this was what actually happened.
Right. Good. Let's go ahead and do that. I move that we approve the change to accept the ZCS bid on the clinic remodel, what do you call it, design, I guess. Second? Those in favor? Aye. Thank you.
Just so that you, just as you know, because this is a public process, those bids are available, and it was requested that I get copies of the outcome of those bids. So that information is publicly available to the other bidders to determine why or if they did not.
Sort of a timeline do we have here, Charlie, to get an estimate or get a, by the time we talk to the doctors and staff?
In the original agreement, or in the RFP rather, excuse me, we had the timeline. That's a good question. I believe the first set of schematic designs would be by July 15th. So they have a little bit more than a month to come up with some, after having met with doctors, talking about the options. And the team was here today. They've already been looking at plans. They've already put the plans that we have on CAD, if you will. So that's computer assisted design work. So they're already working on it. The part that they're working on right now is determining what the cost would be to make any modifications to the building. Because when you touch the buildings, you have to bring them to code. So phase 2, for example, when it was built, it didn't have all the fire code requirements that we would want to have, and we had to make modifications to that. We evaluated the systems, the air handling systems, the lighting systems, just a variety of different things. The sprinkler system has to be all brought into sync with the hospital. The SROB systems, the fire notification, we have to make sure that they're on the same. Right now, they're slightly different systems. So there are several things that they're evaluating, and then they will be meeting with physicians. Okay. We can go through that more if you like. We may do that later.
Okay. Employee recognition.
This time I have a little bit of a different approach. And we have, one of the things that we look at all the time, we're really striving for, as we continue to expand and focus on quality, one of the things that is, without a doubt, something we strive never to do, and that's to have patients have additional pain or suffering while they're here at the hospital. One of those factors are falls. So we have done lots and lots of things to try and ensure that patients don't fall. When they're in the hospital, they get confused, they may lose their balance, they may transfers and all different kinds of things. So with the assistance of, this is something we've been working on often, on both acute as well as long-term care wings and our units. We have tried lots of different things, but with bringing down Dobby here, we've spent much more time focusing on some of the causes of our falls. And we've talked about this in other meetings. Well, one of the things we're doing is keeping everyone apprised of how often people fall. By doing that, we're becoming more sensitized to it. And we have gone 70 days without having a patient fall in our acute care wing. We think that's one of the longest times we've ever gone. And so I want to acknowledge the hard work that our acute unit has put into having a time where we've gone 70 days without having a fall. I think that's exceptional. And that is largely due to Teresa and all of her staff doing it. So there are...
It's that they run every time one of those alarms goes off. Well, not me, so.
Lots of root cause analysis is being done. It's a constant issue, certainly on the long-term care unit. Falls are a terrible thing. We want to stop them wherever possible. But when we deal with people who have confusion or medication-driven confusion, it's hard to do. And long-term care also is very hard at it. But this is really exceptional. But, and we keep knocking on wood that we go another day with their work. So there are employees.
Thank you very much. That's good.
It's a team effort.
Now I guess you got the report, Charlie.
Okay. It's been a quiet week in Lakeview, God.
Children are exceptional.
So I want to remind everyone that on June 18 is Daily Days. We're getting excited about all the effort. Jen has been diligently working with all sorts of people to get that all arranged. And it should be really a good opportunity to see the things that are happening in the hospital. It will also be it won't be the first day that the Saturday market starts. I believe that is going to start this Saturday.
I actually have a change to that. I just got word that they will not be joining us because the downtown revitalization group is doing something down on Main Street, starting at 2:30 in conjunction with the health fair. And so Saturday Market has opted to set it in their regular location. They can't do both, so. But they will be joining us next year. Just got that word.
So, still, we will have lots of good things
Okay.
at Daily Nation on June 18th next, in 3 Saturdays. In terms of Lakeview Gardens, thank you very much, Gerald, and all of you that were participating in the groundbreaking. It was very positive. And thank you, Jimmy, for the front page. That was great. I think a lot of people enjoyed the event and look forward to March 3rd, 2017, when we'll get the keys to all things. Hopefully it'll be done. We did have to make a change to our construction, and that is we've been struggling with an issue related to isolation. And we have worked hard with the state, with the greenhouse folks, to try and make an exception to having an isolation room. One of the problems that we get into is that at a Lakeview Gardens, you don't want to move people. And what we said is the way we would treat patients that have need to be in isolation is that we would, even though we've never had one in 20 years, put them into the hospital. Well, the state is not willing to accept it. So we will be putting the 2 long-term care cottages. One room will be made in isolation. That cost will be an additional $8,500 per room. There's no way we could get it right.
What's the difference in the room?
What happens is the airflow. So you have to have expanded airflow, and it has to be jettisoned out of the main system that goes directly outside.
So if you have a full house and somebody needs isolation room, you're gonna actually have to shuffle people.
Yes, sir. That's correct.
That's too bad.
That does go against the concept that the greenhouse project worked on, but the other option was to spend a considerable amount of money to change the entire air handling system, and the state was not willing to accept it. They did accept this for the other small house projects that they have. There's one, of course, at the Veterans Administration. There's a couple other in the state that they have allowed exceptions on, but they weren't willing to adjust. There isn't anything else we could do. We couldn't come up with any other option. We are presently assessing whether or not we will sign a contract with the greenhouse project. Since we did not get our Weinberg Foundation grant, the way that they advised, the greenhouse project advised us is the Weinberg would pay for their fee. And they had originally estimated it would be about $200,000. We've spent about $30,000 to have the greenhouse project team assistance, and they came out and helped with the design charrette, and they helped with working with the state. And so to go through to the next stage, their original estimated cost was in the ballpark of $150,000. I said I thought that was going to be excessive, and they came back and said, well, we could maybe do it between $80,000 and $90,000, not including the travel costs. And Larry has done some work estimating what our cost would be to send people to the trainings, to learn how to be working in a small house and learning the greenhouse concepts. It is estimated by us that that additional cost for continuing with the greenhouse right now is in the ballpark between $120,000 and $140,000. So what we're looking at doing is if we didn't do that, if we know there's going to be some training that we're going to need to do to have our staff get, as we move from location to location, how they do things a little differently. We'll have some cooking training, we'll have some cleaning, concept training. So we're assessing whether or not it is is worth that additional money. We have a bias right now, but we're trying, that bias is not to continue with the greenhouse project, just because of the amount of money. When we looked at, when Chuck and I and Treva went to the facility in Montana to look at, they too had made that determination and elected not to continue with the greenhouse project. Did it on their own. So we're thinking that it's possible that we can do this and don't use the term greenhouse project. But we'll get back to you. We hope to have an answer in the next 60 days. Okay. We had a JPA meeting, which is the group of hospitals in Oregon. That's Blue Mountain, John Day, and Hector. A couple of weeks ago, we are actively working on a grant, shared grant through the Office of Rural Health. They asked for a little bit of additional information. If we are awarded that grant, as it stands right now, it would be roughly $20,000 per hospital. But we would be working on a lean project together. We're asking for a little bit more money, so it's possible a little more than that. But that's a really exciting thing to be working together. We also talked about sharing some staff, one area being recruitment, both staff and practitioner. So we're looking at how we might be able to work together. We've been a little hampered. I think I told you this, that the CEO at Blue Mountain Hospital, John Day, his Brandon just started a couple of weeks ago. So there's still some acclimation process, getting accustomed to. Brian, you were going to talk a little bit about, give you a chance to talk about the our website and our
The initiative.
Could you talk about that
Sure.
now?
Lake District Hospital and Oregon's 61 other hospitals have committed to give customers cost estimates on scheduled procedures within 3 days. So this gives transparency to the patients and opportunity for us to talk about financial assistance, make payment arrangements, and I mean, transparency meaning they can compare with other hospitals. Our financial assistance applications on our website. We were talking about there's a website on that OHA has published that has
What's OHA?
Oregon Association of Hospitals and Health Services. So there's a website that they publish that gives comparison of pricing and quality measures. And they're going to have that website fully operational in July, but it's partially up right now.
It's not by Oracle.
What's that?
Not by Oracle.
Not by Oracle.
Not by Oracle.
One of the things that we want to try and continue doing with the other hospitals is a commitment to be as transparent as we can. It's often difficult to help the public understand why there are differences in costs or differences in prices. And the more that we can try and be as clear as we can, I think that helps consumers make the kinds of decisions that they need to make.
So the patient can go online and do a price comparison.
That's
That is basically what
We're
that is.
trying to get to that, but as you know, pricing is often difficult to explain.
right now what's on the website is the contact information or the website of the hospital, so the patient can call. If they're in Portland, they can have the contact information of all the hospitals in Portland if they want to shop around for that procedure.
That's a pretty complex thing to try to do if you're going to try to show the actual costs.
That's right. Well, it isn't necessarily actual cost as much as charges. But if you go in for a straightforward procedure, colonoscopy, some people may require more medication than others. Sometimes the procedure takes longer, so that there's longer times. There's a variety of things that can impact the difference in what is charged to a patient. And that's an easy procedure, or easy, not easy procedure. It's an easy.
Thanks for clarifying.
It's easier to explain than a complicated internal organ procedure or other kinds of things that have wide variety of, or variability, or how long a person will be in the hospital for a given condition. That's where it gets to be difficult. And so people are, it's easier to say, well, how much does a CT scan cost? Well, CT scans depends on what? Depends on lots of factors. That includes the radiologist fee, whether that doesn't. So you get, but we want to try and make it as clear as we can in a complicated environment. And that's our commitment. That's what Brian's talking about.
So in the Oregonian, it says that Oregon Association of Hospitals and Health Systems has added cost estimate pages to its website, which is OregonHospitalGuide.org. And this includes contact information for billing departments of each of the 62 hospitals in Oregon.
And so we're also committed to being able to give, if someone calls up and says, what is my this going to cost? Or what are my charges? We are committed to try and give as accurate an answer within 3 days as we can. Again, trying to be transparent.
But understanding that there are variables, you don't know how you might react to some of that.
And so we have to be able to respond to
There's a disclosure, we say that, there may be additional costs depending on the procedure. This is an estimate. So we do our best to give the most accurate information we can, but there's variable factors in each procedure.
We talked in the past about negotiating an agreement with a financial advisory company to help us as we look at our cash and look at our debt and what's appropriate. I believe we told you that Blue Rose Consulting is the firm that we selected, and we are meeting with them next week. So they have our financials, they have the information, a lot of the information. Now is a chance to meet with people. Anyone that wants to come, be 7:30 on Tuesday next week. So if board members would like to sit in, certainly welcome to do that. So I think that'll help us as we look forward to the projects that we're working on. And we'll have a report. We'll get their report back, and they will make a report to the board as you wish, either in person or so. I think I've talked a little bit about how I've been asked to serve on the Hospital Association task force. We met 3 weeks ago, and we'll meet again in the month of June. I believe it's the 3rd week in June. So as all the hospitals are trying to look at ways to ensure that we're as upfront with the public and address some of the concerns that are being raised in different forms. I'll keep you apprised and send you material. Because there's a lot of things that are coming down the pike. Okay? Our medical equipment company, our durable medical equipment company, signed a lease today, and we will be in the Hereford building as of no later than the middle of July. So we're at a storefront location, and we'll be present at the daily days, and these are moving right along. So that's a very positive thing. As you recall, once we have a location, We can have the auditors come out, do an inspection, we can start taking up patients, get Medicare certified. So we look to be seeing a fair amount of business in 4 months or so. But we can start a retail service right away. Wage watch analysis. This is the part that is that which is defined in our Teamsters contract, as well as something that we do every year, effective the first pay period in July. We go and look at our salaries as they compare with other comparable hospitals in Oregon. And we will finish that before the next board meeting. So I'm looking forward to completing that. It takes a little bit of work, so we'll be busy with that. I received a notice yesterday from the town of Lakeview that our geothermal rate is going to be increased by 2.26%. This was written in a contract that rather than have a cost of living increase, this increase is based on the CPIU, and it was averaged over the last 5 years. So it's a 2.26% increase.
Just because they can.
That goes into effect as of June 1st, I believe was the date, and I actually, July, it'll be on the July.
So what are we talking about in dollars and cents per year?
Well, it's $10,000 a year, right? It's just over $10,000. So,
Sorry.
so,
They were just telling us in Rotary how wonderful it is and how we're not using it all.
That's $242 a month.
I'm sorry,
I think $242.88 a month, or just shy of $3,000 a year.
You're so sharp.
That concludes my comments. Do we have questions about any of the projects that we are working on? I'm not sure.
We're going to go into some extensive things in executive session, and I asked Jen to get you each one of these books. And you heard Charlie talk about what is it called, If Hospitals Could Fly or something. This is the sequel to it. It's a good little book, and you'll enjoy it. And I see a lot of parallels. I'm only halfway through it. A lot of parallels to us, even though it's talking about a bigger hospital. It's quite interesting.
If any of you want to read the book, If Hospitals Could Fly, I'm happy to get that for you. It's a fictional story, but it's designed, it's written around the concept. How is it that airlines have a very, very safe record? Very, very few crashes relative to the number of flights and some of the culture that goes into the airline industry to ensure that accidents, if they're found, they study them like crazy. There's a lot of culture that is, they've worked on changing from we don't talk about our errors to we talk about our errors. We don't fire people over errors. We find out why they did. So it's a lot of focus on trying to get to the culture of healthcare. I didn't ask if Teresa wanted to make a report tonight. Did you have anything you wanted to say?
Well, I saw that I wasn't on the agenda, so I kind of phased out, so I.
she's doing her homework.
Let me think. I can't think of anything. Thank you. All right.
We did have a very successful presentation by Kathleen Bartholomew. That really went over well. It's her husband who wrote this book. Kathleen, not Teresa's, Kathleen Bartholomew's husband. Sorry, I didn't mean to.
Bob did, right?
I didn't mean to get any confusion.
back and go into an executive session discussion under RS 192-660, 2, A, C, G, and H, personnel, medical staff, negotiations, and legal. And those remaining will be the board,
Okay.
Dave, Charlie, and any of your staff.
No, I think we're fine.
Okay, and my wife Trina's gonna stay.